Hello, my name is Tamara Vesel. I'm a Chief of Palliative Care Division in Department of Medicine at Tufts Medical Center. I'm here to talk to you a little bit about grief that we as healthcare professionals are experiencing during COVID-19 pandemic. What is grief? Grief can be best described as an emotional and physical reaction that someone experiences following the death of a loved one. Bereavement is the experience of losing a person to whom one is attached. We are human beings with a rich emotional life and attachments to other human beings. Many of us are familiar with what it feels like when a friend or family member dies, and over our lifetime, we develop our own way of processing that experience. How someone expresses their pain depends on a number of factors: on personality, coping mechanisms, one's worldview, the circumstances around the death, support system, and individuals' experience with death in general. Now, what about us, the healthcare professionals? We share a unique professional duty to attend to the sick and dying. We learn about death and dying in medical, nursing school, and other professional schools. During our training and in our practice, we experience the death of a patient we care for. In order to process the death of a patient and assist dying patients and their families in their bereavement process, we do need to contemplate on our own mortality at a much earlier stage of our lives than does the general public. A large study exploring the experience of emotional distress around patients' death showed that nearly 50% of clinicians, students, and physicians alike were unprepared to manage their emotions around the loss of a patient. Another study of internal medicine physicians showed that grief reactions among healthcare workers are potentiated by several factors. 1. Time and process, expected versus unexpected death, peaceful versus chaotic death. 2. Medical care and treatment decisions, treatment being rational versus futile and overly aggressive. And 3. Negotiation, effective communications versus conflictual communications with the family. Each professional has a unique way of processing a patient death experience. These are merely suggestions. In order to prevent burnout among clinicians, it is important to address the death of our patients and our reaction to those events. This is particularly relevant and important during COVID-19 pandemic, which has sadly increased our exposure to patient suffering, death, and the grief that follows. Existing individual and system-level coping mechanisms need to be strengthened, and new ones need to be implemented in order to address this surge. Examples of such mechanisms are death talks that discuss the principal symptoms and complex dynamics of grief, professional grief support groups, death rounds or debriefs on a particular death event, systemic bereavement processes to acknowledge each death through bereavement cards, phone calls, and distribution of resources to bereaved family members, self-reflection strategies and personal awareness of how clinicians are affected by the increased death toll due to COVID-19, writing reflections and diaries to capture feelings, rituals after the death of a patient if possible and helpful, whether individual or group ones, and humor. Additionally, there are a number of strategies for supporting a colleague who is experiencing grief. Learn about their grief, develop empathy, have patience, be a good listener, learn to sit with another person's pain, don't tell, judge, or compare, and offer practical support. As a palliative care physician, I face the death of children and adults on a regular basis. I sit with the grief of others, examine my own mortality, and learn about my own grief. I believe that facing the death of others and seeing how caregivers deal with tragedy creates a space for our own personal growth. I'm humbled to be in the presence of such a private and deep emotional human experience. I truly believe that we can simultaneously and authentically experience our own grief as healthcare professionals while being collectively capable of helping our patients and their families to cope. When we can't cure our patients, we are still capable of healing them and their families. Thank you.